Hello, future mammographers. I wanted to start by saying it was a good lab yesterday. I really enjoyed being there with all of you and going through our basic screening positioning. I will set up another lab and get information out to all of you. I'm specifically going to set up a lab on a Thursday. This is my goal, on a Thursday, so that the students from Concord can attend. So anyway, stay tuned. I will post something or email you all through Jeji. So now we're going to talk about Chapter 17, Diagnostic Procedures. We're going to leave the technical aspects of quality control, quality assurance, and physics and go back to focusing on our patient. So let's get started with this. The primary purpose of this particular chapter is to look at fine needle cyst aspiration, ductography, and pre-surgical wire localization. So let's get started. We'll save the biopsies for another chapter. So it's important for us as mammographers to be competent and to really understand the preoperative localization with a needle. That happens in the radiology department, because although screening mammography allows us to generally localize the lesion and see it, if it can't be felt, the surgeon's going to need help in finding it when she goes to remove it. And this wire that we're going to place in the lesion and or the dye that we're going to place in the lesion is part of a very important job of the mammographer. With 4 out of 5 biopsies proven to be benign, removal of a smaller specimen achieves better cosmetic results for the patient. So if we can localize it well, it's less good tissue that surgeon has to remove when they're going after the lesion. It can be done under ultrasound guidance, mammographic/X-ray guidance, or MRI guidance. It also helps the pathologist because the smaller specimen results in less tissue for the pathologist to examine, so less work on their part. And the specimen radiograph alerts the pathologist to the exact location of the lesion in the specimen. So let's talk about the tools that we're going to use. These are examples of the wires that are used. The wire and needle set comes with a hollow needle that the wire is threaded through. So the radiologist is going to first put the needle into the breast, into the location of the mass. Once he or she has that where they need it to be, then they'll introduce the wire. The wire is going to have a hook on it, or it's going to have a thread on it, and that anchors it. It firmly anchors it into the tissue. As you can imagine, if a patient has a very fatty breast, if it's not anchored with this hook or these threads, it could move around. The compression device is going to have the capabilities of the radiologist to get the needle into the breast. So the breast does need to be compressed. It doesn't need to be as rigorously compressed as you do in the primary exam, but there does need to be compression. It gets the mass that the radiologist is going to closer to the surface, and there's 2 paddles that apply this compression. The one in image A, and you'll see really nice pictures of all of this in your text, but the image in plate A is showing there's holes in that compression. Both of them are going to have an X and a Y axis with letters and numbers to kind of give you a grid placement. But one is going to have different little holes that you can then go in and put the needle through. where the one in image B is just a rectangle with your numbers and letters to help you find the coordinates for that. You do have to make sure that when you're releasing the compression, that you take it off of auto compression on the machine and you release it when you're back with the patient, because you have to release it very slowly and carefully so that that compression paddle doesn't catch that needle hub and remove everything that the radiologist just placed. So the advantages of the circles, for me, that was the one that I preferred. It just is easier to localize the area that you're going after, because you have so many defined places to choose from. Because remember, you're going to leave the compression on through the entire procedure. And the other thing is it compresses the tissue a lot better. If you look at the image, and you can see it better in your text, of the one with just the rectangle, the tissue kind of pillows up. It kind of bulges out of that large rectangle area. And therefore, there's going to be more tissue for the radiologist to go through. It's just easier to work with well-compressed tissue. So I prefer the one with the little circles. You can take a look at that when you look in the book. As I mentioned, they both have the numbers and the letters so that you can use coordinates to identify where the location of the lesion is. So again, I want to remind you, remember to deactivate your automatic compression control at the workstation before the procedure begins, because you don't want to make an exposure, and you will be making exposure when the radiologist gets the needle where he or she wants it to confirm. If you go and make that exposure, that thing is going to auto-release and pull that needle out. And you're going to be starting all over again, because the patient then is going to pull away, move. It's really important to deactivate that. So remember to do that. So when you get your patient there and you have the images, the radiologist is going to tell you how he wants the patient positioned. As it mentions in the book, you want to make sure that you have the shortest skin to lesion distance. So if your mass is in the upper half of the breast, you're going to want to put the patient in a CC position, because that mass is going to be in the inferior tissue, and that's going to be the shortest skin to lesion distance. If the mass is going to be on the lower or superior tissue of the breast, then you're going to want to go with, depending on whether it's lateral or medial, you're going to want to go with a lateral medial view or a medial lateral view. So if you take a look at these images here, that's what they're showing you. Again, you will compress the patient. They'll stay in the compression, but it's a minimal compression force. It's mainly to flatten the tissue out to a certain degree, and to anchor the tissue and keep everything still for the procedure. The needle, the radiologist is going to always, there will be an exception, but always try to set the patient up so that they're inserting the needle parallel to the chest wall. The reason being, and you'll read this in the book, is you don't want to get the needle or the hook close to the pectoral muscle, because as you can imagine, that muscle contracts, and depending on the motions that the lady's doing and with breathing and everything, and if that wire starts to migrate a little, it can be caught by the muscle tissue, and then it's going to move into the muscle tissue. So the needle should be inserted parallel to the chest wall. After performing a preoperative localization, the patient will travel to wherever the facility is that's going to do the lumpectomy. You could be in the same building. You may not be in the same building. So the patient is going to have the wire taped so that it doesn't get dislodged. Patient is going to wear a loose top And a lot of times there'll be a dressing that we put over it, and we'll have a driver to take them to the facility, usually an outpatient surgery center, where they're going to do the lumpectomy. After the lumpectomy is done, most of the time you're going to do a specimen image. There's several different ways to do that. If you're in the same building or you're adjacent to the building, they may run the specimen back to your department and you can do a mammographic image of that. They recommend that you use the magnification platform for that. Then you're using the smallest focal spot and you're magnifying it for easier viewing. It'll, of course, be images on the PACS machine that the surgeon has access to. In addition, the radiologist will give the surgeon a call in the OR before they finish and discontinue the anesthesia for the patient to make sure that they have clear margins. They want to make sure there's clear margins around that lesion, at least by mammographically looking at them. If there may be some mass or lesions that they may not do a specimen of, but whenever there are calcifications, they will always do that specimen. They want to make sure that they're seeing the same number or configuration of calcifications in the specimen that they saw on the mammogram. There's also specimen units that may be housed in the OR department, or you may have one in your radiology department. So you can use that specific specimen radiograph unit, and there's pictures of that in your textbook, or you can just go ahead and do the images on the mammographic unit. So let's talk a little bit about ultrasound. It's primarily used to distinguish whether a mass is cystic versus solid. It's used as a second look at screening in women that have dense breast tissue. Most of the time, a focused ultrasound, what we're most often seeing is when the patient, the radiologist sees something, they recommend a focused ultrasound to determine if what they're looking at is cystic or solid. But today there's also what we call whole breast automated ultrasound. It's a screening tool, and often even if nothing is seen or found on the mammograms, because the patient has dense breast tissue, it may be recommended by the radiologist for the patient to come in and have a screening ultrasound in conjunction with their mammogram. Ultrasound is a very valuable tool to look at very posteriorly palpable lumps when the mammogram has been interpreted as normal. It's not a replacement for mammography. It's done in addition to mammography. It's not able to identify microcalcifications, so therefore it's adjunctive to mammography. It's not instead of mammography. So the breast ultrasound is going to be performed by either the radiologist, an ultrasound technologist, or a mammography technologist that has had breast sonography training. And I've seen it all ways. There may be a combination of the technologist and the radiologist, and that's mainly because ultrasound is very operator dependent. So if something is, for example, a patient can have a very cystic lump in their breast, but if the sonographer turns up the gain too much on an ultrasound unit, they could make what could be purely cystic or fluid filled look like there's solid tissue in there. So sometimes, depending on what the technologist shares with the radiologist, what the images look like, how much confidence the radiologist has in the technologist, they may or may not go in and take a look themselves. Additional interventional procedures that are done would be cyst aspiration, and this would be putting a needle into a cyst and aspirating what fluids you can. Pneumocystogram, once removing the fluid, the radiologist can inject air to look at the contour of the cyst. Ductography is where a cannula is put into the duct of the breast to then inject contrast to check the ducts for any type of problem, usually done when patients have discharge. And then fine needle aspiration cytology. This is putting a needle in there, aspirating the fluid and sending it off to the pathologist. So cyst aspiration, usually a cyst is going to build up and then it's going to back off depending on the cycle of the woman. So the decision to aspirate fluid from a cyst could be made if that cyst is really causing the patient a lot of pain, or it's concealing tissue on the mammogram, or if it just is persistent. A lot of times if the patient says, I just don't want it there, it's worrisome to her, it's painful to her, it's not a big deal to put a needle into it and aspirate to make her feel better. Typically, when you do a cyst aspiration, you do not send the fluid off to pathology. The cyst may refill within a month. If that happens, that may be a reason to send it off. If the fluid they aspirate contains blood, they may determine to send it off. If they feel like they can see lesions or other tissue within that cyst, they may want to send it off, and that's when they would do the pneumocystogram to really see the contour. Or if it's a solitary cyst that is developing in postmenopausal women because they don't have the hormones going on, so it's something that would alert them. Most of the time the cyst just runs with the woman's cycle, but if those other conditions apply, then they may send the aspiration off to pathology. Then it becomes a fine needle aspiration cytology. The pneumocystogram is just like I explained. If the radiologist wants to see the contour of the cyst, they will then, after removing the fluid, then put the same amount of fluid that they removed of air in there so that they can look at the contour. And you can see here they did that, and they can see that there is a little papilloma, or there's a little fibrous tissue there within the cyst. And they will send that aspirated fluid off to pathologists for them to look at that. This particular one, and I think it mentions it in your text, was a carcinoma. Ductography is also known as galactography. This is really a very difficult test for the radiologist to do, so it can be very time consuming for the patient and for the technologist. What happens is the patient is going to be put either in the prone position or in a sitting position. They need to be comfortable because it can take some time. A very small, tiny cannula has to be put into the duct where the discharge is coming from. So usually you have to have that patient discharge some tissue, or the radiologist will, to see what duct the discharge is coming from. Put that very small cannula in, and then go ahead and inject a small amount of contrast, and then do the mammogram. And you can't see it here, but you'll be able to see it better in your book. Well, you can see on image A, you can see that one arrow is pointing to where there's some type of a mass that is restricting the flow of the fluid there in the duct. And so that's what they're looking for, to see if they see any disease there, to see what kind of problem there may be. It could be a benign papilloma, or it could be something that is carcinoma. And then we talked about the fine needle aspiration cytology. It's used to verify suspected malignancy or to confirm benign impression of a lesion that's visible on a mammogram or an ultrasound exam. Fine needle aspiration cytology of a benign appearing lesion can eliminate the need for surgical biopsy. if it's negative, or it can indicate the need for one on a patient whose lesion appears benign on mammography, but whose cytology returns as positive for cancer. So as we talked about in a previous slide, the radiologist is going to take into consideration the age of the patient, whether they're pre or postmenopausal, what would the aspirate look like when they took it out? Did it look bloody or not? Was it nice and clear? Is it painful? Is the lesion painful? And so forth, to determine whether they want to send that fluid off to pathology or if the referring physician is asking for it to be sent off. Fine needle aspiration cytology is selective use for accurate results. The physician must be very skilled at needle placement. The physician must be skilled in how to prepare the slides. And this cytopathologist has to be specifically trained in looking at these slides. Usually, a lot of places will have the pathologist right there. If you're all in the same building, come down while you're doing it, and the pathologist may gather the slides. So those are, with the exception of breast biopsy, and we'll get into that in a later chapter, those are the diagnostic procedures that you will be doing in the mammography department. I do want to make one comment that's not in the text. There is a new technology that is out there for pre-surgical wire localization. One of the problems with wire localization, as you can imagine, is once you get that wire into the mass, the suspected lesion, that patient then has to walk or ride and walk to get to the facility where the surgeon is going to remove the lesion. There may be delays in the surgeon getting the patient done. And so there is an opportunity for that wire to migrate. And when it may have been squarely right in the mass, it may now be outside of the mass. The other thing is, it's really has to be well timed. So the mammography department needs to schedule that needle loc on the same day that they're having the surgery. And you want to get it to, if, say for instance, the surgery is scheduled for 3 p.m., you're probably going to want to schedule the needle localization in the mammography department, say around 1. And, everything has to fall into place. Often the surgery may not be able to be done when the needle localization can be done, and vice versa. So it can be, it takes a lot of coordination between the two departments. So there's a new product that there's quite a few vendors that have it out there right now, and it's an RF radio frequency type of technology. And what happens is the radiologist can put the needle in, and the needle deploys a small, the size of the head of a pin, and it's a little transmitter, radio frequency or a magnetic type of signal. But what we've used most is a radio frequency type of signal that's given off by that. You can put that into the lady's breast, and she doesn't have a wire hanging out or anything. You put a Band-Aid over the breast, she's good to go. That can be put into the breast up to a month, and some vendors are coming up to where it's more than a month before she has the surgery. And then they just need to go to the surgery. Say you put it in today, next week they go in for their surgery. The surgeon has a little device that can find that, the signal of that clip that's in there. So it gets rid of this whole needle wire hassle, and it also helps with the coordination of everything. It also kind of gives the patient a rest to where they're not going through so much. Sometimes these patients have to come to mammography, get the needle put in so that the guide wire can be placed in the mass. She's taped all up, sent over to the surgery center. She may have to go to nuclear medicine so that they can localize a sentinel node because they're going to remove that too, and then she goes to surgery. So it can be a long, long day. So if we could eliminate during that same day having to have the needle localization, can eliminate 1 to 2 hours from her whole process. So that's just, I wanted to comment on that new technology. The one that we were using at Dignity Health is called a Faxitron, and it's a little clip that gives off the signal, and you have the little receiving devices in both the OR and in the mammography department, and you can also see them on your x-rays. So anyway, that does it for this chapter. Please take a good look at the text because they've got really good images to go with everything. And I'll talk to you at the next chapter. Thank you.